So starting off with this patient, this lady who was around 19, 20-year-old young lady who came with severe neck pain. Luckily, no neurological deficit at this stage. And we had to, of course, take her up for surgery. Now, she was actually missing two vertebral bodies and required a lot of correction of the degree of kyphosis, which you can see. The surgery went quite well, and I was able to get a good correction here and put in a good graft of both the levels and put in a plate which was holding it quite nicely. But this patient wakes up with now hoarseness of voice and some difficulty in talking. Especially her voice, the pitch of her voice was lesser and the loudness of the voice went down. So this is something which is a recurrent laryngeal nerve palsy, which can happen in any surgery, and it's a known complication to occur, especially in the anterior exposure of the neck. Mostly it was expected to be due to the direct injury to the recurrent laryngeal nerve, and it is said to be because of increased pressure during the exposure because of either traction or handling. But what we have actually seen is that more than that, this can occur more because of the high endotracheal cuff pressure, and that is one of the commonest causes why this happens. Because of the high pressure in the ET cuff and the retractor blades, there is a nerve entrapment between these two, and that's why this happens. The incidence of this paralysis or palsy is said to vary between 0.2 to up to 24% has also been mentioned. These patients typically, when they get up, they get some dysphonia, the loudness of voice goes down, they may even get some dysphagia and aspiration, and sometimes they may be completely asymptomatic also in spite of having a palsy on one side. The risk factors is that actually it is supposed to be right-sided approach is supposed to be at a higher chance of getting a palsy, because the course of the recurrent laryngeal nerve is shorter here, and so the amount of give that it gives during retraction is lesser. But there is no clinical evidence to show that actually right-sided or left-sided makes any difference. Revision surgeries are more likely to get this problem because you may put in more pressure to the during your surgical dissection to the recurrent laryngeal nerve, and also the amount of retraction that you may do is more. Higher operating times is another risk factor. Multi-level procedures is also a risk factor, and believe it or not, posterior cervical surgeries also can lead to recurrent laryngeal nerve palsies. And this again is because of the high cuff pressure in the endotracheal tube. So how do you prevent this from happening? Number one is a sharp dissection, meticulously going directly onto the vertebral body, using your cautery less over there. A very important thing here is using your retractor blades. The retractor blades should be placed perfectly below the longus colli. You need to make a flap under the longus colli so that the retractor blade stays there and does not slip. If your surgery is too long and it starts slipping, there is a chance that it may go and hit the recurrent laryngeal nerve at the tracheoesophageal groove. If some surgeons even like to use manual traction, and when they use an assistant to hold it, because the assistant may loosen it from time to time naturally, so that also is a method to do. The most important thing which in my practice I have seen is that when I've asked, you should always ask the anesthetist to reduce the endotracheal cuff pressure. Ask them to reduce it to such an extent that it should not start leaking, but at that point. And once if you do that, I have not had any issues with recurrent laryngeal nerve issues after this cuff pressure has been reduced. Intraoperative steroids are also useful in doing this. Now, once if a person does get up with this problem, then what do? Number one is you get an ENT involved early. Let them start assessing it with indirect laryngoscopy to see how the degree of paralysis. You can start some neurotropic medications, pregabalins, etc. Steroids are quite useful. Physiotherapy, vocal cord training exercises are very useful in this, and that actually is the mainstay. Most of the patients recover with that alone. Very rarely, if they don't improve, then they may need some vocal cord injections also are given, and there are some reinnervation methods which can be applied. However, mostly all these are not required. Just normal physiotherapy, steroids, time they do get better. According to literature, 75% of these patients get full recovery and 15% gets partial recovery. Only 10% patients require some aggressive intervention techniques here. It becomes more a problem in patients who are like singers or patients who are going revision surgeries where the vocal cords are very important for these patients, and that is where it is a more of a risk factor than other patients. So in summary, your recurrent laryngeal nerve palsy is a known complication, and you can easily avoid this by doing your clean surgical dissection, quick in quick out procedures, and keep your endotracheal cuff pressure low. Thank you.